Hi, I'm Dr. Frans J, and I'd like to talk to you this morning about the pressure continuum, or if you like, baromedicine. Now, the goal of this presentation is to introduce you to the whole pressure spectrum. You may be familiar with parts of it. For instance, aviators would know the atmospheric aspects, divers would know the hydrostatic aspects, but very few doctors have an understanding of the entire spectrum and how this relates and differs in terms of the challenges that it represents to our physiology. This slide is perhaps the most poignant example of the synergy that may exist across the pressure spectrum. It is an underwater full-scale model of the space station at the Neutral Buoyancy Laboratory at Johnson Space Center in Houston. The astronauts are being attended to by scuba divers, and the purpose of the Neutral Buoyancy Lab is to simulate microgravity in space. The pool is a depth of 18 meters or 60 feet, and both the astronauts and the divers are breathing a 50-50 nitrogen-oxygen mixture called nitrox. This gives them 3 hours to work before they need to consider decompression sickness or oxygen toxicity during the exposure. The point that all human exploration at various frontiers of height, depth, or breadth of our world ultimately produces critical deviations from the pressure-oxygen spectrum required to sustain life, and ultimately each of these boundaries exceeds human tolerance. As a result, much of the technological, physiological, and medical support we offer represents precautionary measures, physical manipulation, compensatory mechanisms, and clinical management of complications that may be associated with this challenging pressure-oxygen boundary, irrespective of the medium in which it is performed, that is, whilst being in a gaseous or liquid environment. The reason why I have been asked to present the material today is because I'm perhaps one of relatively few double agents, if you like, in the industry, meaning that I have both aviation and hyperbaric expertise and interests. Nevertheless, in working in different environments, either in a research or clinical setting, both in altitude and hyperbaric environments, I've had the privilege of the unique perspective on the pressure continuum, which I'd like to share with you today. So when we consider baromedicine, we really have two aspects. There is a hyperbaric component, which traditionally extends from half a meter onwards to an indefinite depth, which for practical purposes on our planet is down in the Marianas Trench, which represents a pressure of 1,100 atmospheres, to the hypobaric side, which is essentially the vacuum of space. This page will be very familiar to those in the audience involved in aviation medicine, and this is the hyperbaric counterpart, the webpage of the Southern African Undersea and Hyperbaric Medical Association, which makes available a database where divers are able to verify their qualifications, and doctors are able to certify divers as fit to dive or unfit to dive, either temporarily or permanently. The benefit of this, of course, is that there is continuity and divers are unable to doctor shop. An organization that some of you may not be aware of is the Divers Alert Network, which essentially is a hotline for injured divers, but also a place where medical information can be obtained. There are many resources, and I encourage you, if you have an interest in diving or develop one, that you check out the Divers Alert Network site. There are many training and other opportunities and of course reference materials that would be very relevant for individuals interested in this particular field. For the sake of simplicity, I've structured this talk into 5 parts: the pressure-oxygen continuum, the medical and clinical landscape, the legal and statutory frameworks, the operational and clinical contrasts, and the training and certification that is available in these related disciplines or subspecialties of the field. Again, for practical purposes, if we consider the pressure-oxygen continuum, we have in our universe at least an excursion potentially to the depths of the ocean, the so-called Marianas Trench, which represents 1,100 atmospheres of pressure into the vacuum of space. Apart from the pressure spectrum itself, the predominant differentiating factor between hypo and hyperbaric spectra is the environment associated with it. For hypobaria, it is typically air, with aviation medicine being the tandem discipline. In aerospace situations, the composition of the environment may of course be altered. Still, the contact medium remains gas. For hyperbaria, it's usually water, whether salt or fresh water, with diving being the proponent disciplines. Water is not breathable and has high density, which means that one needs to provide breathing gas under significant pressure or maintain a 1 atmosphere cocoon like a submarine or bathyscaphe in order to get the diver to the environment that they wish to reach in the water column. To perhaps give you a better appreciation of what we're talking about, let me show you some contrasting situations between aviation and diving. As we descend in our atmosphere of ocean of gas, which we call air, we eventually reach the surface of the ocean of water. At that point, the absolute pressure is 1 atmosphere. If we descend further in sea or fresh water, we find that for every 10 additional meters, or 33 feet, we add an additional atmosphere of pressure. In terms of operational considerations, we can afford to consider sea level as the 0 pressure, whereas if we're working in physiological terms, it's important to also account for the influence of the atmospheric pressure column. To really contrast the pressure excursions between aviation and diving, let's consider a typical commercial flight at 30 to 40,000 feet cruising altitude, where the typical cabin pressure would be 8,000 feet, the equivalent of 10 psi, pounds per square inch, or 690 millibar. So the descent from 8,000 feet to sea level represents an increase of 4.8 psi, or 331 millibar. This is the equivalent of a descent from the surface of the sea to 11 feet, or 3.3 meters. And just shows you the contrast between the two. The point is that in aviation, this pressure excursion typically occurs over 20 to 30 minutes, whereas the same excursion may be reproduced by a simple plunge to 3 meters in water, which can occur within seconds. So the need for a prompt pressure equalization of airspaces is far more critical in diving than it is in aviation, and the demand is greatest near the surface. Similarly, the vulnerability to pressure overexpansion or pulmonary overexpansion injuries and gas embolism is far more profound in the hydrostatic exposure realm than it is in air exposure and aviation situations. Irrespective of whether the pressure increases or decreases, and whether it is in water or in air, we need to support optimal human function in a way that is both sustainable and safe. And the challenge is therefore both technical and physiological, and there are variables that we can manipulate. There are many implications when we do this, and it often represents a compromise between safety and costs. Obvious variables include the range of partial pressures of oxygen, the choice of inert gas, gas mixtures, the means of gas delivery, the technical, physical, and fire safety issues that need to be considered, and the pressure range to which the whole system needs to be subjected. As far as oxygen partial pressure goes, there's a relatively narrow spectrum range from 0.1 to 3 atmospheres that is able to support normal human function for varying amounts of time. Long-term adaptation is possible between 0.12 and 0.5 atmospheres, but outside of that, pathological effects supervene sooner or later. Pulmonary oxygen toxicity is a familiar complication of exposures to oxygen greater than 0.5 atmospheres. What is unique about the hyperbaric pressure spectrum is that it is possible to breathe oxygen at pressures greater than 1. Above 1.4 atmospheres, there's an increasing probability of oxygen-induced seizures. The latency period decreases as pressure is increased up to 3 atmospheres. This is also the reason why there are dose time tables that are used in recompression and hyperbaric oxygen therapy settings. The danger, of course, with a diver having a seizure is that drowning is very much a likely outcome, and that is an additional concern. So the goal is to stay within an environment that is safe for unselected individuals, which in diving is a maximum of 0.14 atmospheres of oxygen, whereas in aviation it is 0.14, which translates to 8,000 feet cabin altitude. As long as one stays within those environments, it's likely that the individual will be able to remain, certainly for the duration of a typical flight or a typical diving exposure. But even within that range, it may not be appropriate long term. And so in saturation settings, sometimes a compromise is made and the choice is selected of 0.35 atmospheres, which, as you can see, is halfway between 0.2 atmospheres, which is essentially what we're breathing at sea level, and 0.5 atmospheres, which is where pulmonary oxygen. So there's a range that we need to observe, both operationally, therapeutically, and of course, just from a medical and physiological rationale point of view. The process of actually achieving the goal of an optimal breathing mixture is obtained in different ways and for slightly different reasons in aviation versus diving. Aviation relies primarily on cabin pressurization and oxygen supplementation. For diving, the situation is far more complex. With increasing pressures, the air soon becomes unsuitable to breathe. Apart from the oxygen toxicity, the nitrogen then becomes narcotic and so needs to be substituted with a less narcotic gas. Going even deeper, one then also needs to consider the gas density because breathing resistance may become a problem. On top of all of this, one has the challenge of decompression sickness. And so one needs to consider both the breathing mixture and the ultimate operational issues related to returning to the surface. Just to illustrate an extreme form, in 1981 at Duke University, where I did my clinical and research fellowship, there was a series of experiments in which divers underwent a simulated dive to 686 meters. And at that depth, they were effectively breathing the equivalent of 35% oxygen at sea level. But what it meant was that the oxygen had to be diluted down to a 70th, or if you like, 0.5% oxygen at 70 atmospheres for them to be able to breathe it over the 21 days they were at that depth. So again, it just contrasts the magnitude of pressure excursions that we encounter in diving environments. From this, it's very easy to see that in aviation, the main challenge is in preventing hypoxia and hypocarbia, with the reverse being the case in diving. Here, oxygen toxicity and hypercarbia, due to breathing resistance and dead space, are the most pressing concerns. The last unique perspective related to the pressure-oxygen continuum that I want to point out is that in aviation, the route of safety involves compression. In other words, landing or an increase in pressure is how you get back to safety. In diving, it is the reverse. To get to safety, one has to decompress and get back to the surface. Now, using as a very simple example that of a pneumothorax, in aviation, landing is actually a form of treatment for a pneumothorax, as the increase in environmental pressure will actually reduce the size of the pneumothorax. Conversely, though, on the hyperbaric or diving side, a small pneumothorax may very easily become a tension pneumothorax, and therefore we are far more strict in considering individuals that are vulnerable to pneumothoraces in diving. And unlike aviation, where there's an algorithm where a certain number of pneumothoraces could be tolerated before pleurodesis is required, a single spontaneous pneumothorax essentially precludes an individual from further diving. So before I shift gears to the clinical, operational and training sections, let me just outline baromedicine for you with an emphasis on the hyperbaric spectrum. After taking you through this outline, I'll show you examples that will allow you to make better sense of the various medical and operational issues. With hyperbaric environments, we have essentially two streams, the activities and therapies. The activities are relevant because the legal framework within which they occur are entirely different to those of the therapies, although there's obviously some overlap. The activities are governed by the Occupational Health and Safety and Mining Acts, and the major stakeholders are the oil, gas and petroleum companies and the various diving contractors. Diving medical examiners at different levels of fitness to diving versus occupational medicine are involved, and which we'll get into shortly. The training organizations, the professional peer organizations, academic institutions, and ultimately the divers and hyperbaric workers themselves, all are a particular breed or category that is somewhat different to those that would be considered in a therapeutic setting. On the therapeutic side, this falls in the spectrum of medicine and health, and although the therapy may be provided as part of treating occupational injuries, such as recompression for decompression illness, it is still governed by the diving regulations in our country. Otherwise, the spectrum is governed by the various acts on health professionals and medicines, and various health facilities, licensing organizations, hospitals, employers, healthcare professionals, professional peer organizations, academic institutions, and ultimately the patients and allied health workers are all involved in those activities. The therapies are usually described as either recompression, that is for diving related problems, or hyperbaric oxygen therapy, which is for the broad range of clinical applications. Although they are technically part of the same therapeutic strategy, they typically occur in vastly different environments and are governed by different legal and statutory instruments. Recompression, for instance, is part of the professional health and safety related to the diving work, whereas hyperbaric oxygen therapy is a clinical modality and usually associated with a medical facility or hospital. As for the activities, these may be wet or dry. The dry type include compressed chamber work, such as, for instance, a nurse attending to a patient who is receiving hyperbaric oxygen. The other includes work in various pockets of compressed gas related to, for instance, excavations and civil engineering, such as building bridges or over rivers or tunnels that pass through underground water sources. These are called caissons. The wet activities may be recreational or professional. The latter may be commercial or military diving. Recreational diving, in turn, is split between different levels of sport, where you may either have dive trainers and supervisors, which are called instructors or dive masters, and the simple lower level of divers themselves. That brings me to the medical and clinical landscape. Again, we mentioned that hyperbaric therapies are governed by the medical and health-related organizations and legislation. For those unfamiliar with hyperbaric oxygen therapy, this modality is employed in several distinct clinical situations where oxygen is breathed under increased atmospheric pressure. The consequent increase in plasma-borne oxygen offers several therapeutic advantages that cannot be achieved otherwise. Exploiting this mechanism, as well as several other associated therapeutic effects, makes up mainstream HBO. And this is a list of the acute and chronic conditions that are considered mainstream. And as you can see, they involve acute gas bubble disease, certain acute poisonings or toxicities, infections, ischemias, and certain chronic wounds. This is just an example of an individual with a mangled ear, and as you can see, as the individual is exposed to hyperbaric oxygen, the ear pinks up very nicely as the patient breathes oxygen under pressure, and the diffusion distance increases by a factor of 4 or more. The medical or clinical landscape is covered very carefully. Doctors are primarily considered the users as far as legislation is concerned. So if accidents occur, fires break out, or there are adverse events that happen, it is usually the doctor that is held primarily responsible. There is an occupational health component because you have staff that are exposed to hyperbaric conditions and may also be under the same health risks as patients are. And then, of course, the facility itself should be safe. So on the hyperbaric side, involving therapies, when it comes to recompression, though, we're looking at treatment of gas bubble disease. And these are very rarely primarily situated in hospitals, although it certainly is true that many patients are referred to hospitals to receive recompression for diving-related injuries. Provision must be made for recompression to be available on-site or very near to on-site where diving operations take place. So the medical clinical landscape, as far as the recompression therapies are concerned, one needs to consider the medical supervision, the diving regulations, the issues related to access and transport, and rescue and medical emergencies. And this requires significant thought and planning, and often significant amounts of telemedicine. Let us briefly look at the legal and statutory landscape when it comes to activities. Here we have the wet and dry variety, as we mentioned, and if it involves chambers, that would fall under the occupational health and safety and labor relations issues, because you have staff that are exposed to pressurized environments. When it comes to the dry exposures, we consider caissons specifically, and these may be the building of pylons in rivers, where you literally have an inverted bucket that allows you to make your way down to bedrock and dredge out the mud, and in the process, to keep the water out, the pressure within that environment increases, and so workers in those environments need to observe decompression schedules. Similarly, tunnel boring machines may operate in environments that are pressurized, such as was the case with the Gautrain in the Rosebank section. There, individuals needed to be diving fit, even though they were essentially blue-collar workers and were doing very mundane activities. They nevertheless had to be declared fit to dive or fit for hyperbaric exposure. We're still at the activity side, looking at the wet activities, and now moving to the professionals in this realm, which are typically commercial divers. And this may include commercial scuba, which, for instance, underwater photographers would use, surface supply, which typically is what would be used in ships, husbandry, and fairly shallow sort of diving maintenance operations, wet bell diving, which may go down to 30 meters or so, and dry bell diving that can go in excess of 150 meters, depending on the diving environment. Underwater mining typically is fairly shallow diving, although it may be very hazardous because of the surf zone in which the diamonds occur, and of course the rocks and all the other things that may be involved while dredging diamonds. So that has its own set of hazards. Underwater work, as far as commercial diving is concerned, falls under the Occupational Health and Safety Act and specifically the diving regulations, whereas underwater mining falls under the Mine Health and Safety Act and the underwater mining regulations. Still sticking to the wet activities on the professional side, there's the military. And of course, the military is a bit of a paradox where we have very, very strict standards of safety in times of peace, whereas in times of war, one has the obvious hazards of hostile activities, and therefore it would be inappropriate to try and apply the occupational health and safety diving regulations to a military context, although it does follow some of the guidelines as is appropriate in certain settings. So now we lastly go to the recreational side, and here we have divers. Divers may be breath-held divers, and there's a wide range of those, and then the typical scuba divers that do it for fun, typically in beautiful but often remote areas, and if they run into either diving related problems or even medical issues, then it may present significant operational challenges in getting the individuals to appropriate medical facilities. There are a variety of diving training agencies that are recognized internationally, and the way in which this area is governed is that the recognized training agencies issue divers with a so-called C or certification card, which then allows them to have their diving cylinders filled by a dive store, the absence of which would then typically lead to a refusal for the cylinders to be filled. Recreational divers, of course, are under no obligation to be fit to dive, just as people who want to climb mountains are not subject to specific medical standards. But why it does become relevant in diving is because in a training setting, whether it's a resort or an instructor, there is a certain amount of liability. And so in the recreational diving sector, the driver behind the medical standards is really the legal requirements or the means of indemnification to a certain extent for diving instructors, diving operations and resorts that drives that process. And that may be more or less lenient. And when looking at divers in this setting, their physical, mental, and social responsibilities are considered. Mental, they should be able to be trained and not be anxious in the water. Physical, they should be able to wear the equipment and use it safely and appropriately. And social, meaning that they should not represent undue liability to the organization that's training them or taking them on excursions, but also towards their dive buddies, because there is a tacit understanding that divers dive in pairs that are mutually supportive, meaning that if one gets into trouble, the other is supposed to help them. And therefore, there is a certain expectation that an individual should be able to fulfill that commitment. And there are ways in which that is dealt with. This is a typical diver training outline in which divers may start as snorkelers, and that's become far more popular in recent years, especially breath hold diving, or scuba, self-contained underwater breathing apparatus, upon which, after 5 dives, an individual does a second course, and after 10 dives is considered an advanced diver. From there, divers usually split into 2 groups and either go towards specialties if they have a particular interest, or towards leadership if they consider making a career of it. So most recreational diving really falls in the sort of holiday divers that happen to be in a resort or in an area where a diving experience can be arranged, which is very, very basic. Individuals or families that go on diving holidays, badge hunters, which are becoming fewer and fewer, and technical divers that often are diving pioneers and push the limits of depth or length in the case of tunnels, and set records, and unfortunately sometimes get themselves into trouble. And then lastly, we have the dive leaders, and those are either dive masters, assistant instructors, instructors, or instructor trainers. And they are technically commercial divers or professional divers, but as yet are not formally accounted for under the diving regulations, although this is in the process of changing. And so in closing, we look at the operational or clinical contrasts, and here they're the pressure volume implications, inert gas and bubble disease implications, the effects on vision and hearing, infection control, environmental factors, and rescue or buddy responsibilities. Diving is very much focused on gas bubble disease, and that is a significant operational concern. So decompression illness, which covers both decompression sickness and gas embolism, which synonymously could be called dysbarism, as it is also used in languages other than English that don't really make a distinction between illness and sickness. So dysbarism may be used, covers the umbrella of gas bubble disease. Now, decompression illness can occur in pilots, but is very, very rare. And usually descent treats it quite effectively. And if treatment is in fact necessary, it usually responds very well. In divers, if you dive for an extended period of time deeper than 6 meters, there is a fair chance that you could develop decompression illness, whereas a lung overpressure injury is unlikely to occur shallower than 40 centimeters under the surface of the ocean or a pool. But that's quite shallow. It's only about 4 feet. So one can get significant gas bubble disease even if you haven't dived very deep. And that's just something to know. There are certain patterns for decompression illness that vary based on the activity. And the biggest problem that we face with diving from an operational point of view is usually a failure to equalize the middle ear with the tympanic membrane and middle ear being damaged to varying extent. So that's the most common problem clinically we see. Small blebs, that would be a non-issue in aviation, may cause pulmonary barotrauma and gas embolism in diving. So that's another area of emphasis we really need to look at. And this is an actual case of a diver who developed arterial gas embolism, fortunately from a relatively shallow dive, and made a good recovery. And then there's the rescue buddy situation, which is true both in the commercial as well as the recreational setting. In closing, just training and credentialing. There are various ways in which general practitioners or specialists can train themselves to extend their specialty or practice to include either fitness to dive or diving operations versus hyperbarics and a medical directorship of hyperbaric units depending on their qualifications. Anaesthetists are very popular because it overlaps with many aspects of their field, and they make a very, very strong contingent in Europe and Australia, for instance, where most of the hyperbaric medical directors are in fact anaesthetists. Whereas in America, it's the American Board of Medical Specialties, either preventative or emergency medicine, that makes up the brunt of. There are a number of institutions related to diving. We have run out of time, so I can't address each of those, but please feel free to email me if you want further information and or are interested in getting further training. And the training is available in the form of the BSc Med SC Honours degree in underwater or diving medicine. If you don't want to do the full degree, you can actually start with just the basic hyperbaric medicine course and exit with the qualification of being able to do fitness for diving assessments or selection of patients for HBO, depending on which of the two tracks you choose. If you take it to the second module, you then have competence as in diving operations or hyperbaric medical directorship. And if you then continue with the degree, there's an advanced component, a research component, and then personal coaching with a final exam leading to the BSc Med-SC in underwater or hyperbaric medicine. So with that, we have reached the end of our discussion. And just to say that the qualifications are recognized by the leading organizations in the world, and we hope that the overview that we had on baromedicine has filled in some blanks for you, raised some questions, I hope, and please feel free to email me and or get hold of me one way or the other, and I'd be happy to answer the questions for you if I can, and if I can't, I probably know someone who will be able to do that for either the hyper or hyperbaric individuals. Thank you very much.